Good afternoon. Today I will present a critical overview of the Infection Control Management Plan, or ICMP, for the intensive care unit context. My focus is a certain regional ICU, but the issues discussed are relevant to any ICU, being as infection control in that critical care must move beyond policy compliance and become part of the day-to-day clinical governance. What's being covered in these slides? We'll briefly cover the ICU background, discuss the rationale for the ICMP, how it's developed, how it should be implemented in practice, and finally how it should be evaluated and revised over time. The overall argument is that an effective ICMP is not simply a document, it is a living governance and quality improvement framework. The hospital being reviewed for this is a 395-bed regional facility within a tertiary health district. Its ICU is a 10-bed adult level 2 unit funded for 5 ventilated patients. It manages approximately 450 to 500 patient admissions per year, which matters because ICU patients are highly vulnerable, frequently require invasive devices and are exposed to antibiotics and complex interventions, which means even small infection control failures can have significant consequences. The rationale for the ICMP is both legal and clinical. At a legal level, Queensland legislation requires health facilities to have a documented infection control management plan. At a clinical level, ICU is one of the highest risk hospital environments for healthcare-associated infections due to the overwhelming number of lines they will generally have, from central lines, urinary catheters, ventilation. They're having frequent procedures and close staff-patient contact with one-on-one care. Therefore, the infection control management plan is justified not only as a compliance requirement, but as a core patient safety and staff safety strategy. The development of the ICMP should be understood critically as a process of localization. National and state standards provide the framework, but the plan becomes meaningful only when adapted to the specific ICU environment. In this case, the plan is developed using the Queensland Health Infection Control Guidelines and the Queensland Health Infection Control Management Plan template. But it is then shaped by the multidisciplinary input from ICU management and staff, infection control, the ICU medical team, nursing leaders, pharmacy, infectious diseases team, operational services, sterilisation services, education staff, and executive governance. This multidisciplinary structure is important because infection risks in the ICU are distributed across many systems and not just bedside nursing. The plan identifies the major local risks that require control measures. These include transmission through hand hygiene, staff non-compliance, transmission-based precautions, poor aseptic technique during invasive procedures, infection from invasive devices, environmental contamination, workforce-acquired infection, failures in reprocessing reusable equipment or following the reusable equipment processes, and antimicrobial resistance. A strength of this approach is that each risk is paired with controls, monitoring processes, and assigned responsibilities, which makes the plan operational rather than theoretical. Implementation is where many infection control plans succeed or fail. In the ICU, implementation is strongest when the ICMP is embedded into existing governance and workflows rather than added as a separate project. That means using Standard 3 meetings and ICU safety and quality meetings to review surveillance data, audit findings, incidents and improvement actions. It also means ongoing staff education, the standard mandatory annual training, aseptic technique assessments, hand hygiene assessments and audits, pharmacist participation in antimicrobial stewardship rounds, and daily visibility of device guidelines, hand hygiene prompts, and transmission-based precaution signage. A critical point is that implementation must involve stakeholders, not just target them. Frontline staff need structured opportunities to report barriers and provide feedback on practicality. Support services such as the operational supports, engineering and sterilisation need to be involved because they shape whether infection control expectations are feasible. Consumers also matter significantly. Patient and family information, patient-reported experience measures, and consumer representation in governance all strengthen the accountability and acceptability of the ICMP. Evaluation of the ICMP should occur through both process and outcome measures. Process indicators include hand hygiene compliance, aseptic technique audits, environmental cleaning audits, and education completion. Outcome indicators include healthcare-associated bloodstream infections, resistant organisms, device-related infection trends, and staff exposure incidents. These data need to be reviewed through incident reporting systems, root cause analysis, and national safety and quality healthcare standard gap analysis, so that evaluation leads directly to action rather than passive reporting. To look at all these aspects critically, briefly discuss the perspective the plan to discuss these the strengths, limitations of this plan. The clear strength is its evidence-based, legislatively grounded, multidisciplinary, and linked to clinical governance. However, like many infection control programs, it may underperform if staffing pressures, variable adherence, limited feedback, or weak follow-through reduce implementation fidelity. For this reason, the ICMP should be treated as a living quality improvement tool. Its value depends on whether the organisation can convert surveillance, audit, and stakeholder feedback into practical bedside change. In conclusion, the best way to implement an ICU-ICMP is through an evidence-based, multidisciplinary, and governance-embedded approach that is practical for frontline staff and responsive to stakeholders. When the plan is regularly evaluated, transparently reported, and revised using local data and national standards, it supports not only infection prevention, but also a broader culture of safety, accountability, and continuous improvement in intensive care. Thank you, and here are the references that have been used to complete the ICMP for ICU.